Probably one of the trickiest procedures to try to apply the miniSQUAIR to is with mastectomy. And the important thing to remember is that it's the strength of the suction and the movement of the amount of airflow that will carry the smoke to the collection device. What you cannot do is put this over the breast so that it will interfere with the surgeon's ability to feel the skin flap and the thickness of the skin flap. Therefore, the best you can do is to put it along the inframammary fold of the breast up toward the axilla. The incision will be over on the breast side, right on top, centering around the nipple. And you'll find that even though the skin flaps are being developed inferiorly and superiorly, the smoke will leave the operative field and be collected at any of these cell foam areas, so long as the airflow is adequate, 25 to 35 cubic feet per minute. In the case where there is a local excision of a recognized tumor, perhaps at this location, upper, outer, or inner quadrant, or lower inner quadrant, and an anticipated sentinel node lymph node biopsy, the device can still be positioned in this position and will draw the smoke away for any of those incisions. It could be positioned inferiorly and do the same thing, or it could be done this way as well. It's always better to take the top side for the incision, since smoke rises. But this would be perfectly adequate for a local excision and sentinel node biopsy. The next incision is the midline back incision for posterior cervical fusion or decompressions. And here again, the same principle. Put it as, and it doesn't matter whether you put it on top of the outer surgical drape, the clear surgical barrier drape, or the prep but dried skin. The principle remains the same, and that is to put it as close to the line of incision as possible. You can see that the flexibility of the device allows it to remain adherent. For those who might be concerned that a long scoliosis incision may be too long for the device, realize that the open cell foam is 9 inches long on the miniSQUAIR, but it will draw in smoke and air for another 1.5 inches at either end. So you're really covering an incision up to around 12 inches. The second incision that we're going to apply the miniSQUAIR adjacent to is the midline incision. Again, remove the release paper, very sticky surface, and you put it on as close to the line of incision as possible. Press it in, and again, it is put on the dried prep skin on the surgical barrier drape or on top of the outer surgical drape, depending upon the preference of the surgeon. You can square off with the towels. And your surgeon is ready to go. Now we're up to the Mid-Sternotomy Incision, and again, after the wound is prepped, the skin is prepped and dried, the release paper is taken off, the adhesive layer is now exposed. Just put it as close to the midline as possible. It will stick with a little pressure. You can square off at this point. And the surgeon is ready to start the incision. Remove this white release paper from the device with the tab, and it's pulled straight down. You remove it. This is a very sticky surface, so it's meant to be once and only once. We're going to start with the Pfannenstiel incision. It's placed as close to the line of incision as possible. You put it down, and that will be either on the dried skin, recently prepped, or if you have a surgical barrier drape, that, or the outer surgical drape last. But the point is, put the open cell foam as close to the line of incision as possible. At that point, then, it's a question of squaring off with towels in the usual way in which you do that. And you can see as the process continues, the device literally becomes almost invisible and will not distract you from your surgical procedure. Be aware that you can use any kind of retractor that you want to, either handheld or mechanical. As long as you don't compress the entire device, there will be adequate surface area to absorb the smoke and capture. For replacement knee surgery, where the incision is placed on the midline anterior over the knee, the device can be placed, we believe, most easily on the medial side, again, as close to the line of incision as possible. The adhesive is quite strong and will stay attached during the multiple flexing and extending of the knee that's required during the surgery. Once applied, once again you towel off. Now, in this particular instance in the knee, it may well be that your surgeon does not want to use towels but uses a surgical barrier drape and also will use a tourniquet. In those situations, the device should not be applied until all these manipulations are completed. In other words, the outer barrier drape is on, the tourniquet has been applied, and the wrapping has been removed. Then you would put the device on, and then you can towel off, as we're doing now. If towels are not used, which they often aren't, there would instead be a clear surgical barrier drape underneath over the prep knee, and this and the miniSQUAIR would be attached to the clear surgical barrier drape. And instead of these, only an outer surgical drape would be on the wound. The next position, we're going to assume a lateral hip incision. We've already removed the release paper, very sticky at surface. And this is also placed as close to the line of incision as possible. This can also, of course, be positioned laterally if the surgeon prefers. This seems to have been, through experience, seems to be the place where it's least in the way. As a matter of fact, not in the way at all. And again, retractors can freely be used to separate the incision as the surgeon goes deeper without any problem. Now up to the final area of concern, the perianal area, but this also holds for the anterior introital area, where you can put the miniSQUAIR as close to the line of incision as possible. In this particular case, it can be up above or to either side, and that would be just as satisfactory as a smoke capture device. For our purposes, we'll leave it right here. Again, flexibility allows it to be adherent to any body contour. Just cover it over. This certainly would be appreciated in cases of fulguration of perianal condylomata or perivulvar condylomata.